Good morning, everyone. Welcome to this session on health systems strengthening. Once again, this session is on health systems strengthening. We already had one gentleman looking for a different session, so make sure you're in the right session. I welcome all of you to this, what I hope will be a very exciting session with an amazing cast of our panelists. My name is Adnan Hyder. I'm the Senior Associate Dean for Research at George Washington University, Milken Institute School of Public Health in Washington, D.C. I'm also an adjunct professor at Johns Hopkins Bloomberg School of Public Health, one of the members of the M8 Alliance. And I'm honored and delighted that today I get to moderate this session on health system strengthening. I'm sure many of you in the audience are already familiar with the need and the importance for strengthening health systems to actual achievement of goals. And in fact, the Sustainable Development Goals, which now guide us for the next several years in our health system actions. And so the question, I think, today is going to be how. How are we going to achieve those SDGs? What are the pathways for actual implementation and activation of national health systems together with their subcomponents, and how can we really enforce that around the world? I think one of the goals and visions that we've all signed on to is universal healthcare. And so I hope today we will at least hear a mention or two of UHC and see how can health system strengthening be a key component of achieving UHC. I also hope that today we have an explicit discussion about the need for vertical programs and achieving goals in specific diseases, in specific conditions, all important. But at the same time, how do we do that in a way that enables a generalized and horizontal structuring of health systems across our countries? This becomes incredibly important, particularly when we talk about low and middle income countries. I also hope that today, with the diversity of panelists that we have, we are going to talk about different sectors and their engagement, the public sector, the private sector, the foundations, the academy. How can all of us, coming from our different perspectives, rather than view each other with suspicion and distrust, how can we work together in a collaborative model? I also hope that in this conversation we will not forget the people that we are supposed to serve, the public. What is the role of community engagement, community participation in health system strengthening? I hope that we will have a dialogue that stimulates these discussions. And I really hope that we will have time after the opening statements by our panelists to engage you all. I know that many of you have an incredible wealth of experience and expertise in different parts of health, and I hope that we will be able to have a good dialogue, if possible, a provocative dialogue, and engage each other in not just agreement, but also in challenging each other to see how we can make a better world with better health systems. I'm really honored at the quality of our panelists today. I'm delighted to first introduce our opening speaker. I'm honored that the World Health Organization is here with us, and really privileged that Dr. Rüdiger Krech is with us, Director of Universal Healthcare and Health Systems at WHO in Geneva. Rüdiger, of course, has been in the space of health systems for many, many years, not only with the World Health Organization in Geneva, previously with the European Office of WHO, with the German Development Corporation, and so on. He comes with not only the expertise from a global lens, but also having the experience of working with bilateral agencies in country and seeing the issues at heart. Rüdiger, we would love to hear from you and give an overall perspective from WHO on health system strengthening. Welcome.
Thank you very much, Adnan, for that kind introduction. Ladies and gentlemen, a very good morning to all of us. So I headed my presentation, Health System Strengthening and Achieving the SDGs, Building Health Security and Creating Healthier Lives. And to make a statement at the start, I think that's the biggest issue at hand, because very often we see ourselves in competition for funding between health system strengthening or disease-specific or population-specific programs. And I think we have to get over that, because there will be no universal health coverage if we don't invest in people, in population-specific interventions, so for specific needs of people, or if we would not have disease-specific programs. The other way around, there will not be advancement in really reducing the burden of disease if we don't have very good, resilient health systems. And so, therefore, I think that's the first message I want to convey, is that we need to come together on universal health coverage. Now, before or at the start of my presentation, I would like to congratulate Minister Manu. In Ghana, you have eliminated trachoma, and you're the first country that has eliminated trachoma in Africa. Now, why do I say this? Of course, I want to be nice to you, of course, Minister, but I say that because if you want to eliminate trachoma, you need to work with many sectors, and you need to engage the community. You need to involve every person to really understand what the trachoma challenges are. And if you do not do that, and if you don't counsel people as well, you will not have that success that you have. And that is my second message, is that you cannot do any of the programs in isolation if you really want to be successful. Now, if we want to achieve the SDGs, then we need to break down the issue, right? So if you want to achieve the SDG 3, this means that in the next 5 years we need to reach a triple billion. 1 billion more covered for health interventions. So that is the universal health coverage goal. You need to make 1 billion people safer. That is the health security agenda. And you need to ensure that 1 billion more people can enjoy healthier lives. And that is the population and disease-specific agenda I was just talking about. The goal 3.8 on universal health coverage means that there's, first of all, financial risk protection of people. So people should not spend out of their pockets when they need health care. They should receive quality, essential health care services. And I say that because we need to also understand what the quality aspects of universal health coverage are. So there is no point in just covering people and there's very poor quality in services. So we need to ensure that these services are quality services and that they have access to safe, effective, quality and affordable essential medicines and vaccines for all. And I'm looking very much forward to our colleague from Merck to show us a bit more how we can do this. We had great discussions on supply chains, for instance, but how can we actually do this much better? Now, universal health coverage, if you can see that, this is a map about coverage. And if you allow me a little bit of gymnastics here, if you can see that there was actually an increase in coverage over the last 20-odd years, in order to achieve universal health coverage by 2030, we need to really make something like this. We need to really do different business differently. And that means here that you can see how coverage looks like. We have about half of the population of the world not yet covered, and that means that we really need to shift gears. You might ask how health system strengthening is actually related to this universal health coverage goal and to the SDGs. And I just, without going much into detail here, I've just tried to outline that health systems strengthening is actually the action you need for the goal of universal health coverage. And with this, you're not only achieving the SDG 3, the health goal, but also you will reduce poverty, you will contribute to quality education and gender equality. And of course, we know that investing in health has a lot of economic benefits and benefits for decent work. So actually this goal is contributing to other SDGs as well, and I'm very much looking forward to this afternoon when we will talk about the SDG 3 Global Action Plan and to see how actually the different UN and big health organizations, and I'm looking forward to our interventions by the Gates Foundation. So how can we actually all work better together for achieving the health SDG? Now, sustainable development goals are all about leveraging domestic resources. And that is part of the, where I would say, part of the discussion that went in a certain direction in the early 2000s when we wanted to have quick wins. Very much the global community actually dominated the real health work. The real health work is financed by domestic resources. Only 1.5% of the overall health spending is due to international financial substitutes. Only 1.5%. So, but that actually very much dominated the design of disease-specific, population-specific, or system-specific programs. And I would argue that we need to look much more into the domestic resources. Even in fragile states, 75% of the financial resources are domestic, and 95% in middle-income countries and emerging economies. However, most of the fragile states and middle-income countries spend far too much on out-of-pocket spending. So we need to really reduce that in order to make health systems more equitable and more accessible for all. So what sort of specific support does that mean? And these are the areas that you all very well know that constitute the areas of health system strengthening. So this is where you would see interventions coming. I'm showing you this slide because we have developed 3 strategies. Because if we're asked how do we as WHO contribute to the strengthening of health systems in our partner countries, we cannot do everything in all countries. And I think also that wouldn't be useful. But we have therefore developed 3 strategies because very often you find environments in which you need to look much more into the foundations of health systems. Other situations where you want to look at the institutions of health systems, and a third area where you want to look at transforming health systems to meet the challenges at hand. So that doesn't mean that these 3 strategies are just groups of countries, but you can actually, in one area, very much need to look at your foundations, and in other areas you might actually look into how you're developing your institutions or how you actually meet the challenges of demographic or epidemiological trends. So the typical problems you would have in the strategy when we are looking at foundations are that you have an under-provision. You have underutilization. You have a lack of financial absorption, you have a very low density of health workers, you have shortages of medicines, or lack of basic infrastructure. And then the key areas for support would actually look at the pre-education pipeline, the training of statisticians, accountants, pharmacists, managers, looking at the financial management system that you have, looking at the supply chains in countries or the basic infrastructure, or also the local governance systems, like, as Adnan, you said, how to engage with the community to make the system really needs-oriented. And this is a typical way how you would then see health centers or hospitals look like. And I don't want to go into this, but this is a whole menu of interventions in the area of financing, governance, workforce, information, pharmaceutical products, and service delivery. So I don't want to go into any of these specifics, but just to show you that then once you go into this, there's sort of a menu of interventions that you may want to choose. And in the institutions, that's the same. It's then perhaps looking at how you develop organizational capacity for reforms, including a legal framework that you would have. So that's for the area of governance, or for the area of workforce, you might actually look at the health labor market analysis, or how you actually support the development of curricula, the pre-service or in-service education of programs for health workers. Or in the transformation, the typical problems would then be the over-provision, the complex entrenched institutional setup with historical, political, escalating costs, the quality, the misalignment of service delivery and financing to health challenges. And I'm sure that many of you coming from very high-income countries will face exactly those problems. And so the key areas of support there would be the intelligence functions, the reform agendas, the interagency coordination. And also here you have quite a bit of a menu in these 6 areas that you may want to look at. Why am I showing you all this and an unreadable slide? This is because you will see in all these dots, in all these points, in foundation, in institution building, or in transformation, that many of our development partners are very active in. And very often, we do not really analyze and be clear about whether the environment in a country is more on the transformative stage, or in the foundational stage, or in the institutional stage, in this particular problem. And so very often we do the third step before the first. And so my third message today is we should all look at how we can align ourselves, how we can actually establish an understanding what needs to be done and how we can support countries in strengthening the health systems, align the strategies which are behind each of these dotted points there, and then to see what are the sequencing of actions that we all need to apply in order to be very effective. Thank you very much.
Thank you very much, Dr. Krech, especially for reminding us about the important organizational frameworks that WHO has for us to look at, but also your reminder that health system strengthening is fundamentally about leveraging domestic resources. I think this is a really important point, and maybe we can come back to that in our discussion. I'm now deeply honored to introduce His Excellency, the Minister of Health of Ghana, Mr. Kwaku Agyeman-Manu, who has been the full Federal Minister of Health for the past couple of years, and previously with extensive experience in the public sector. It is under his leadership that many of the reforms in the Ministry of Health in Ghana and in the health system sector there are actually occurring. And I fundamentally believe that irrespective of how we in the academic sector or at the global level discourse about health system strengthening, it's actually on the ground that change is needed. So, Honorable Minister, we would love to hear from you about the changes you've brought about in your health system and the challenges for the future. Thank you very much for coming.
Good morning. Let me thank WHO for recognizing what Ghana has managed to do, elimination of trachoma and its announcement. I wouldn't take the credit. I cannot. It started long ago, but we worked continuously to reach where we got to, with the support of donor partners and WHO. And we have an agency within the health system, Ghana Health Service, which actually championed the actual work. Communities were involved. A few pharma companies were involved. And I think we've achieved tremendously what the world never anticipated would be achieved in a very short time anywhere in Africa. Health system strengthening is the only way we can improve upon service system. In the Millennium Development Goal era, there was a lot of investments in siloed systems. Very little effort was attached to health systems strengthening. Even in cases where we did health systems strengthening, there were more of siloed efforts for Gavi, Global Fund, and other ODA's activities, and there was no comprehensive health systems strengthening framework in most countries. Despite impressive vertical efforts against priority diseases, the health systems that deliver and sustain life-saving interventions are ailing and weak. Too often, as USAID Administrator Raj Shah has said, and I'll quote, our siloed single disease focus means that in many countries, the same health system that can prevent the transmission of AIDS to an infant is unable to prevent that same child from dying of diarrheal disease before she turns 5. Quoted. We see health system weaknesses in the form of poor stewardship and governance, dysfunctional service delivery, inadequate and unskilled workforce, non-availability of health information systems, lack of access of essential medicines, vaccines, and technologies, inadequate financing, lack of community ownership and participation, slow efforts for partnerships for health development, low investment into health research, and inadequate research infrastructure. Ghana has made strenuous efforts at health system strengthening over the years, and I will go back to pick some of the pillars enumerated above to demonstrate what my country has done so far. Before I was appointed minister in last year, 2017, the previous 8 years saw 7 different ministers in the health ministry in my country. And I believe you will agree with me that that never will get well for any good governance, stewardship, leadership, for policy, and even for implementation in the sector. Dysfunctional service delivery, we had challenges, a lot of weaknesses. We were not linking ourselves so adequately. Inadequate and unskilled workforce. We have trained doctors, several of them. But like we heard in one session yesterday, like Malawi, more Malawian doctors in Manchester than in Malawi as a country. Ghana alone can boast of about 1,200 doctors in the state of New York alone. So when you get in country, in the 2 big cities, you will find a large number of our doctors, well-trained, highly skilled. They can do all surgery interventions. Some trained in Germany here, elsewhere, but they are just not adequate to go around the country. As I speak, we have established close to about 98 nursing and midwifery training institutions, all of them functioning, training a lot more to enable us achieve primary health care to support our efforts towards achieving universal health coverage. Non-availability of health information systems. Last 2 years, we couldn't speak of so much. But today, apart from what Ghana Health Service is running for data capture, we've placed tabloids across the country in rural communities, and our health workers in there give us information online, day to day. We have piloted a seriously integrated system that will capture all work that is done in any facility linking all facilities. Our pilot had gone to close to about 30 facilities in one region. And we are just at the verge of rolling out that comprehensive package across the country. And that will solve virtually all our health information system challenges. Lack of access to essential medicines, vaccines, and technologies. When I joined the ministry in 2017, Ghana has failed to even pay co-funding Gavi what we should pay to give us vaccines. But Gavi never put off their list. Thank you, Gavi. They made sure that we got the vaccines that we needed. This year we haven't paid. We have negotiated to pay by close to the year. We're expecting that Gavi will not put us off, and Gavi will continue to give us what we need, despite the fact that we are failing even to put up. To enable people to have access affordably in our country, government last year removed value-added tax on all medicines that are imported into our country. And through that, and part of our strengthening our supply chain systems, we have introduced framework contracting. And I've signed agreements with close to about 16 distributors and manufacturers who are giving us medicines at the same price across about a year before we renew prices if there is the need for us to do so at all. Inadequate financing. I think Ghana is the first country in sub-Saharan Africa to have introduced or established health insurance system. And the levy that we started with is still at the same rate. The premiums that we're taking from people are still at the same rate. And because of that, with growth in population, the finances that are coming via that window isn't just adequate. And we are now looking at options to see how we can augment or improve on soliciting or raising resources to do just that. Lack of community ownership and participation. We are making efforts to change our legislation, the law that guides the implementation of service delivery, to make it that communities will be involved in service delivery at all levels. Low investments into health research and inadequate research infrastructure. Virtually, we don't even seem to have any budget line item for health research. There are efforts. We have 3 small health institutions, one large one that works for even the entire West African sub-region. The Noguchi Center is seriously being sponsored by Japan. And thank you, Japan, for that effort. In fact, during the Ebola crisis, that was one facility that was actually doing tests of samples that have been sent from across Nigeria, Cameroon, Guinea, everywhere. And we can boast of that, but that is not just adequate. Though Ghana has made strenuous efforts at health system strengthening over the years, on assessment, there is ample evidence of the nation's achievement in health system strengthening, but we still have to put a lot more investment, and we don't have so much long way to go. We are just getting close to that end. We face challenges, not only in Ghana, but across the sub-region, and probably even extended across the entire Africa. Inadequacies in the workforce, health workforce that I've mentioned, inadequacies in financing, weak procurement and supply systems, along with poor information and monitoring systems. The efficiency of health services delivery is overall affected by poor governance and organization of the health sector. We have a Ghana Health Service, which is a government institution charged with service delivery. It has facilities across the country, from the rural communities to a district level, as well as the regional capitals, and it even moves on to the national capital. There are 5 teaching hospitals that provide secondary and tertiary care, a number of mission hospitals, Christian and Muslim hospitals, as well as private sector facilities of all sorts throughout the country that provide care. Yet, collaboration and partnerships among these groups of care providers has not been the best. Even data capture, the private sector data, finds itself very difficult to get into the mainstream Ghana Health Service data that gives us all health data that we have in the system. So we still have a few more things to do there in terms of collaboration and building partnerships in country. We've done partnerships across. There is one teaching hospital that is linked with the teaching hospital in Tokyo, which does a lot of cardio-surgical interventions. They move in from Tokyo, about 10 of them, every 2 years, come to support the Ghanaians. They do their work. Ghanaians move in there to also look at what is there that they can help to do in Japan. We have a facility in Germany here that is also linked with our teaching hospital in Accra, Kolebu, partnerships again into cardio. The Chinese have linked up with one of our district hospitals, and they're doing so much in there. We have a facility in America that is helping one regional hospital in Koforidua that is doing orthopedic interventions. They also come and sit 2 months and take away backlogs of interventions that they should have done for patients. Go back with Ghanaians, they train them and things like that. So we are building partnerships, but that is not adequate yet. We face challenges of antimicrobial resistance and the high incidence of substandard and fake drugs in the marketplace. These are a few of our challenges. Strengthening of health systems is key for the achievement of all the targets of the SDG Goal 3. It can be said that effective health systems are the backbone for the achievement of the SDGs. Health systems need to incorporate a comprehensive package of services in order to ensure the attainment of universal health coverage. We in Ghana believe that a window of opportunity is opening for meaningful health systems reforms. This is being driven by epidemiologic shifts such as aging populations, by increased public awareness and expectations for affordable, accessible care. In addition, as we have gone beyond the second year of the SDG implementation, we can seize the momentum to steer reforms toward better health outcomes and financial protection, especially for the poor and vulnerable groups in countries around the world. Improving human resources and scaling up specific health services are critical to this enterprise. We in country are embarking on the comprehensive human resources reform. I've set up a ministerial committee on HR in health to ensure our current resource policy will be fit to deliver on the SDGs. But that won't be enough. To measurably improve the health status and financial resilience of the poor, we need to build a global movement in support of universal health coverage, which WHO defines as access to appropriate health services for all at an affordable cost. Critically, to ensure we strengthen our health systems, we need to improve upon our measurement. This will ensure we really leave no one behind. Perhaps the fundamental lesson of the MDGs is that macro-level progress can often mask troubling trends when you look beneath those averages. Disaggregated data by age, sex, wealth, location, disability status, and other dimensions of inequality are particularly important for monitoring progress among different income social groups. Disaggregated data, however, is not also enough on its own. There must be an explicit prioritization on the progressive reduction of inequalities over time as part of the SDGs follow-up and review framework. I thank you.
Thank you very much, Honourable Minister. And I'm particularly delighted at your frank assessment of health system strengthening in your country. Your reminder to us that changing 7 ministers in 7 years or whatever it took is an issue of governance for health system strengthening. The fact that you have issues in human resources for health and the migration of highly skilled technical workers, the push and pull factors, incredibly important. So thank you for that on-the-ground vision of health system strengthening. And I think that lends itself very well to your mentioning the role of other donor agencies and foundations. And I'm really delighted that we have with us today Ms. Sandhya Venkateswaran, who is the Deputy Director of Gates Foundation in India. She is the country lead for policy and strategic initiatives, has been working with Gates for several years, and really comes from the development sector. And I'm looking forward, Sandhya, for you to talk to us a little bit about health system strengthening from your perspective, both in terms of one of the leading foundations in health investment, but also from a development perspective. Thank you for being here.
Thank you, Adnan, and thank you for this opportunity. I also want to echo your words that it was really wonderful to hear the Honorable Minister lay out in a very open and transparent, honest manner the challenges that lie ahead, and some of these challenges actually resonate with many other countries, so it was actually really valuable to hear that. Let me begin by some good news. So the good news is that in several countries around the world, health outcomes have changed significantly, driven, of course, by many factors, such as economic growth, focus on social determinants, the right medical interventions, technology, and, of course, a strong focus on health systems. If I were to give the example of India, we see that in India, between 1990 and now, a woman is half as likely to die from childbirth as she did then. Polio and maternal tetanus have been eliminated, and India is today a driving force for the manufacture of generics. So just to say that there's been a lot of progress, and India, I just give India as one example. We heard about Ghana. We'll talk about other countries as well. So while there has been progress and much to celebrate, the job is not done. There are many, many challenges that lie ahead, and several countries are continuing to face a high disease burden, as well as high costs incurred on account of healthcare. Again, I want to turn back to India. While I gave a positive metrics, the reality is that 500,000 children in India continue to die today before their first birthday. Infectious diseases such as TB are yet to be eliminated, and almost 40% of children are malnourished, are underweight. And scarily, between 4 to 7% of the population falls below the poverty line on account of health-related expenditures. It's very clear, therefore, that while there is progress, there's much to be done. Several countries have undertaken improvements in their health systems. We've just heard Ghana's experiences. Many other countries have done so across continents. From their experiences and their learnings, there are 3 key features of health systems today that I would like to identify. One is the whole issue of vertical systems. Honorable Minister also made a reference to that. And while there is value in vertical disease-focused approaches, there is also a challenge in not having integrated systems, as the Honorable Minister highlighted. Given the shifting focus on NCDs globally and in many, many parts of the global south, that underlines the need for integrated systems much more today than ever before. That's one. The second feature I would like to underline is the private sector. There is clearly a recognition on the important role of the private sector, yet a strong understanding of their nature within the larger health ecosystem is not quite there. Bringing the private sector into the larger health system today has really gone beyond a purchasing role in many, many countries. We talk about the UHC. The question on the table is, can the world achieve UHC without actually engaging the private sector meaningfully and without a proper regulation on costs and clinical protocols? The third feature that I want to talk about is financing. Financing in many countries has been fragmented with multiple resource pools, which basically take away the potential to leverage a large pool for systemic gains. Countries with fragmented resource pools experience much of healthcare being provided by the private sector, paid for by patients themselves, out of pocket, at the point of service, and India is a prime example of this context. It's very clear, therefore, that continuing with the same approaches is not going to lead us to our goals. If we want to accelerate progress, we need to shift the gear, and transformation in the health systems need to be brought about. Again, looking at countries around the world which have actually brought about health reforms, there are 3 key issues that I would like to highlight that might be very valuable for countries to focus on. One, financing, as I just talked about. Current context of financing is fragmented, and we need to look at how can those be consolidated into larger pools. Very often countries talk about the quantum of resources that governments invest. That is no doubt important. Public contributions are very important. But often it happens that even though the governments may invest less, the total health expenditure in countries is significant, but they still suffer from achieving health outcomes because of the way that financing is designed and constructed. Let me give you an example of India vis-a-vis other countries. In India, public health expenditures are very, very low, about 1.4% of GDP. But as a total expenditure, India spends between 4 to 5% of GDP, which is really not bad. When we compare ourselves to other countries, Thailand, Sri Lanka, Bangladesh, with similar or maybe even lower resource investments, we find that their health outcomes are better. Why does that happen? That happens because of the way the total health expenditure has been actually constructed. The problem with fragmentation of resources, that the high out-of-pocket expenditure continues to strain the individual's financial stability, as well as the ability to demand quality and accountability in services, which a large consolidated pool will be able to do. An area of financing reforms, therefore, points to pooling of small contributions so that large amounts can be paid by the pool and not the individual, thereby protecting the individual from falling lower down into poverty because of health expenditure. Interestingly, many countries have the building blocks of such reforms. Even if I were to look at my own country, India has such reforms. There is 1.4% of tax payments. There are employee insurance schemes for blue-collar workers. Recently, the Prime Minister, some months back, announced a very, very large, perhaps amongst the largest tax-based insurance scheme for the poor. And then there are, of course, private schemes. If these were expanded and consolidated, that would provide the potential to actually gain from the system. The second area of focus that I would like to underline is provision of health services. Several countries have mixed system of health provision, both public and private. However, fragmentation of these and the lack of overall stewardship of the entire provisioning ecosystem can lead to two completely separate systems and missed opportunities of efficiencies and effectiveness. In India, again, I think pretty much 2/3 of health services are accessed from the private sector. The government, however, focuses on the part that is delivered by the public system and not the entire health delivery system. Therefore, a health provision architecture focused on aggregation and oversight of the private sector can address the extensive fragmentation of a varied private sector, as well as be able to set regulatory and purchasing interventions that can move towards a floor for quality and a ceiling for cost, which is very, very important. Because right now, with an unregulated private sector, there is often the condition of high costs. And of course, quality, I would say both the public sector and the private sector have challenges of quality. The third and my last point is on governance and the use of technology. I think it's widely understood that a strong technology platform and robust use of data analytics can go a long way in improving quality, preventing fraud, and managing overall efficiency of the system. Many, many countries, again, have the building blocks. India has a lot of technological capacity. We need to point it in the direction of health systems. Governance, again, Honorable Minister spoke about the importance of stewardship, the importance of leadership. None of these reforms or none of this health system strengthening is going to happen if there isn't political prioritization and a political push, not only to introduce reforms, but equally to ensure that the reforms are operationalized effectively and that there is continued political attention to these. And the last point as part of this is the importance of institutions. When we look at countries such as Thailand, they paid a lot of attention to building a variety of institutions on research, on data and analytics, on prioritization in terms of health technology assessment. All of these institutions need to be part of an ecosystem that is looking at transformation of health systems. India has begun on this journey through the national health, NHA, national health body for the insurance program that it has launched, as well as an institution that is working with states to build capacity, as well as health technology assistance. Hopefully, the country will continue to focus on these so that the interventions that have been launched will continue to become stronger. Thank you.
Thank you very much, Sandhya, for your intervention there. And I think the way you phrase those three important issues of financing, of provision of health services and governance is very useful for us to dig a little bit deeper. And also it was wonderful to now have an Asian example of India, and thank you for contributing that in addition to the Honourable Minister's Ghanaian example. This is very healthy. Finally, I'd really like to invite a number of our already speakers have talked about the private sector. I'm so delighted that Dr. Stephen Hildemann is with us today. Dr. Hildemann is the Global Chief Medical Officer for Merck. He's also the head of patient safety across the organization. He has been leading in this position for several years. But what I found very interesting is that he's a professor of medicine and a professor of cardiology at the University of Freiburg, which means that he has kept his hand on the pulse, so to speak, of the patient. So I'm really looking forward, Dr. Hildemann, to your intervention about the role of the private sector, the decades of work that Merck has done, and how it can contribute to health system strengthening.
Thank you, Adnan, for having me as a part of this distinguished panel. Ladies and gentlemen, Merck this year has celebrated our 350th anniversary, which makes us the oldest pharmaceutical company in the world. And we have been in Africa for nearly a century. And what I can present today briefly is just a snapshot of the activities that we are doing in very concrete terms across Africa in this particular place. And it's a pleasure and a privilege, really, to present this on behalf of our colleagues of the Merck Institute of Global Health and Corporate Affairs who are in the audience today. So very briefly, we will talk about our approach to health system strengthening in R&D, which is, of course, my spheres of activity. Commercial operations will introduce a little bit an outlook to our social business model and charity work. And we'll present a few examples of programs we do in Ghana and in other countries across Africa. But let me start on a very brief personal note. You see here in the back with his khaki sweater and white shirt, Bidogo, who is a godchild of my family, the third one in his generation. He lives on the outskirts of Ghana and is an exceptionally bright young man. We've had the pleasure to support him through high school, and now junior college. And lately we have a bit of an argument because he didn't get quite the notebook PC he envisioned, just like my two other sons. So he now has to cope with life without a high-resolution graphic card. But I'm convinced that as time goes on, he will still be certain that he has a bright future instead of a slow graphic card. Health system strengthening. Through R&D, we focus on tropical diseases through the Merck Institute of Global Health in low and medium resource countries through education, knowledge transfer in very concrete terms, in my own group in drug safety, but across the company. We have a very all-encompassing approach to access to medicines and other key metrics in this space, and through generating capabilities and real infrastructure on the ground. And our principal philosophy is that sustainable business should be the principal driver of this, in addition to philanthropy. A very quick look at the Merck Institute of Global Health. which of course focuses on infectious diseases. We have Dr. Jutta Reinhard-Rupp, who heads the institute, here with us in the audience. Merck has been engaged for decades in the eradication of schistosomiasis that many of you know very well. And we collaborate with the Gates Foundation and others in this effort, but also have a sophisticated, emerging preclinical and now clinical pipeline in malaria, with a very promising malaria effort, which is in early stages, first in human, but nevertheless, we find it a very promising approach to a potential one-pill cure to malaria. Again, early stages. And all of this is a very collaborative grassroots effort across many, many countries. Health system strengthening. So we have a few examples now. You see the geographical map here right in front of you with a couple of countries in East Africa, in West Africa, and in the South highlighted. And I want to just mention maybe a few examples. The minister mentioned counterfeit drugs in his speech, a huge problem across the continent. As many as 25 to 30% by volume of drugs may be fake. And one of the approaches that Merck serves with is a so-called mini lab, which is a self-sustained suitcase free of electricity connections, where you can actually detect counterfeit drugs of the most common 70 or 80 drugs in healthcare, which has proven to be a very, very efficient tool. We develop in our life science division devices like the Muse device, which is a very small, simple measurement that allows a one-prick blood test to identify malaria, HIV, and in the future, other diseases. We have, of course, research sites across all of these countries where we do pediatric studies on schistosomiasis. As you know, this is a waterborne disease that infests mainly young children and infants through access to sweet water. We have postdoc programs across many of these states. We work with a large number of the universities across Africa in PhD programs, and we bring fellows back to Darmstadt in exchange programs. Now here's a snapshot of some of the activities by the Merck Institute of Global Health. On the left, you see the World Malaria Day in Ghana. Your Excellency, which was a great success. We introduced free malaria screening and signing of a memorandum of understanding with Ghana. On the top, you will see in Ivory Coast the refurbishing of a phase 2 study site. And if you see the before and after picture, I'm not sure if the laser works. It doesn't. Oops, sorry. You will see the difference before and after. And of course, the donation of medical devices is a standard effort as part of what we do. Knowledge transfer. Merck has long been a partner and sponsor of a German industry initiative which is called Afrika kommt, Africa is coming. And we do this, we've done it for generations of interns. We do this because we genuinely feel that these people are brilliant and that this is a win-win situation. And we have genuine talents here that I will take my head off. You see on the right, Esther and Dambiri from Nairobi. You see Daisy Gracie and Eugene, both from Ghana. They are pharmacists, they are scientists, they are MDs. They come with enormous knowledge and hands-on expertise to Darmstadt. They stay with us for about a year to 18 months. And typically then they go back to their country. And you now see Daisy Gracie on the bottom here on the right. After her return, she works in the Regional Service Center for Pharmacovigilance in Africa. And she, no sooner had she landed in her country that she's already engaged in WHO collaboration and training programs on pharmacovigilance, spreading her knowledge across the region. And that is really what we find important. And they give so much to us in Darmstadt. They are really an inspiration to us. And working with them is a pleasure. A few comments on access to health. I will not go into the sophisticated methodology here. You have sophisticated experts here in the room of access to medicines. We have the 4 A's, what we call the 4 A's at Merck, which is availability, affordability, accessibility, meaning the supply chain, and of course awareness in types of medical education, patient-centric materials. There is an access to health index, which is measured by an independent NGO that has very sophisticated and granular parameters and metrics. I think more than 60 go into the score. But fundamentally, it's what the corporate DNA of an enterprise is with respect to access to medicine. And what I can tell you that whether it's our charitable work, our social business models, or quite frankly, our personal engagements, this is something that at Merck we take very seriously, from our owner family that have deep personal ties to Africa for generations and generations to all of us working at Merck, which is why we are proud of this particular ranking. In the Access to Health Index, at least the last running, we came into 4th place. Not that we're competitive, but very close to Novartis in number 3. So we have an ambition to continue to rise against many companies that are multiple size in terms of our own size. But again, this is about the leadership in our patent management, the transparency of how we manage our patents. In essence, it's how we continue to develop drugs which have been off patent for 50 years, glucophage, for example, in diabetes and pre-diabetes, that are 86% or more genericized. But we believe it's a public health obligation to develop the pre-diabetes indication and do the right thing for patients. We talked about capacity building, briefly about R&D partnerships. Of course, we do work in malaria, on schistosomiasis, in diabetes, thyroid diseases, and cardiovascular diseases. But we also develop our innovative pipeline in oncology, in immunology and immuno-oncology, in part in Africa, which is very important because if any of you have ever been to oncology hospitals across Africa, the standard of oncology care really leaves a lot to desire and is sometimes very touching. I will skip a couple of other best practices just to say that the Access to Health Index is something that drives much of the work that we do, and it's nice to collect it in this fashion. Access Accelerated is another initiative that Merck is a part of. You see important partners here, such as the World Bank, the Global Cancer Control Consortium, UICC, which looks at the dire need of cancer care, as I've said. This is important because it focuses on non-communicable diseases, which at this meeting take a little bit less of a focus than multimicrobial resistance and some of the antibiotic challenges that we have, but of course is a major, major public health challenge for emerging countries. A number of principal goals after the first 3 years have a demonstrable impact on patient lives. That's easy to measure, but hard to reach. To sustainably move along to get the NCDs in place, as our previous speakers have said very eloquently, effective partnerships and reforms, and a more sustainable long-term outlook. Now let me close again on a very pragmatic, hands-on, on-the-ground approach to building and strengthen local infrastructure, which we call KGaA. Very briefly, this is an integrated service unit. You see it here on the bottom. A very easy to build infrastructure that can be set up in a very short period of time, sometimes in days, that offers a continuum of services. And this building will ultimately be leased out to pharmacists, to clinicians at very low cost or even below cost, who operate and manage it with our logistical support, our scale-up, and our knowledge and expertise. They cover, you see the 3 different areas with a dispensary that's in a way our pharmacy with a very sophisticated online real-time supply chain. You see in the center a service area, which is like a mini pharmacy. And on the right, a nurse or physician's area where actual healthcare counseling and support is provided. And this operation offers a wide range of services, basically whatever comes by, day to day. From insurance services and coaching, initial low-level diagnostics and therapeutic approaches, counseling, and on-the-ground health needs. There is sophisticated digital support as far as you can have it in the field. And ultimately, we see this as a nucleus of an evolving service level on the ground. So let me summarize on behalf of my colleagues in global health. This has been just a snapshot of some of the hands-on key programs we do at Merck. Behind it is an overarching strategy on health system strengthening that goes all the way through the R&D and pharma value chain, from early R&D into commercial operations, life cycle management, and so on. We put a sustainable outlook on business at the center of what we do. There are some aspects we experiment in terms of social business model. There's a major charity effort by the Merck family and the corporation itself. And we would put this out there now for discussion as potential pieces to the complex puzzle of resolution. Thank you.
Thank you very much, Stephen, there. First, congratulations on the decades of work that the private sector like yours have done. I hope we can get a little bit unpack the notion of the sustainable business model and the sustainable health system model and how they can interact with each other. And thank you for reminding us about non-communicable diseases and the importance of focusing on that. So ladies and gentlemen, I want to thank all the panelists for staying within time. So we have over 20 minutes now for some interaction. You have in front of you the Honorable Minister of Health, the World Health Organization, Gates Foundation, and a 350-year-old pharmaceutical company, which is amazing. So please, I really want to engage you. I have a ton of questions myself, but I'm going to hold my own questions to my heart and see if I can catch my colleagues during the break. I do have the capacity to see hands over there, and I think we have somebody due. Is there a microphone on that side, and is there one on this side? Okay, great. Yes. So if I could get the hand of the gentleman right there, I'm going to take a few questions, and you have microphones in front of you, and I'll ask you to reflect. Yes, the gentleman right there. Also, if you are unable to ask your question in about a minute, I'm afraid I'm going to have to stop you because we don't have the opportunity to have more speeches, okay? So you have a minute to ask your question. Yes,
all right,
sir.
I'll make it snappy. My name is Alex Peters. I'm currently a research fellow at Harvard's program in global surgery and a student at the School of Public Health there at Harvard as well. The first is just a quick comment. I worry that in the name of health system strengthening, we're often conflating top-down financing with bottom-up financial risk protection. And that's to say that in almost every country around the world, often those who are able to pay to access care get it, and those who can't don't. And so I think there's a critical difference there to focus on. My question, though, is how can we, at the global level, at both public and private levels, address the often misallocation of resources that occurs in global health? And so for an issue that's near and dear to me, polio, which has had enormous focus from the Gates Foundation, over $500 million, and has 70 people working on it at the WHO, had 37 cases in 2016 and even less last year. Whereas surgical care, which is near and dear to me, of course, has 1 person at WHO and little focus at Gates and other organizations. So how can we address some of this misallocation of resources if we're going to start to address health system strengthening? Thank you.
Thank you very much. We clearly have a safe surgery person in the room here, and indeed, very important. Could I get a question right there? The gentleman here.
Thank you, Tobias Binder from the Hertie School of Governance, PhD student there. Question to Mr. Hildemann. What Merck is doing now in terms of health system strengthening, clearly, you want to answer before my question?
Yeah.
what Merck is doing now clearly goes a little bit further than the classic corporate charity of just donating medicines, and I think it's a good move. But now I'm asking myself, how do you align your activities in health system strengthening with the demands and the needs of the countries that you work in, and also how do you kind of balance that with the fact that you need to tie it to your business strategy to sell it to your shareholders?
Thank you very much. About alignment, and I have a hand right at the top there, a lady. If you could stand up for a second, then I can point these out. Yeah, these lights are incredibly challenging for me to see people, but we will get there. Yes, please.
Sort of as a follow-up to that, I was curious. In the United States, pharmaceutical companies have a reputation for the inequitable consolidation of wealth, often at the expense of the patient. So one of the key buzzwords that I've heard throughout this entire conference has been incentives. What are the financial incentives that a pharmaceutical company has to address the inequities in global health?
So clearly both of those questions operating around this whole issue of the private sector, incentives and alignment. I'll take one more and then I'll go and request the panel to reflect. And the lady right there.
Hello. I'm Deepika. I recently finished my PhD from India on health financing and governance. And my question is for Ms. Sandhya. Since you mentioned the critical importance of involving private actors into the process of achieving UHC goals, given the weak capacities that we have, specifically in the context of India and maybe other lower and middle income countries, the weak capacities that we have with the government, most likely this purchasing and provisioning divide ends up in government handling only like managing and monitoring these private actors and the contracts. And we end up asking the questions that how are these contractual arrangements or the partnerships defined clearly in terms of the roles and responsibilities, specifically in the sense of how do we hold these private actors accountable, because not every time their interests are aligned with the public services. So, yes.
Thank you. By the way, I am so excited that we have young professionals, students, PhD graduates. This is really remarkable. So I'm going to request we'll start from that end. Stephen, if you want to, and any panelist can respond to any of these questions. And if you wouldn't mind staying within 2 or 3 minutes, that would be fantastic. Please.
Sure. To the colleague from the Hertie Institute of Governance, let me start with my R&D hat. Developing new medicines, whether it's for schistosomiasis or malaria or other, you clearly go to where the disease is and where the patients are. You need some level of sophistication to support clinical research, so you can't do a complete grassroots effort, and that largely drives the countries and the sites we choose for our infectious disease programs. We then typically try to embark on a capability building exercise that at some point will allow us to do the innovative research that we do for oncology, immuno-oncology, immunology, and we're happy to have a footprint of that in some major tertiary hospitals in Africa as well. So that's the R&D head. You go to where the patients are. The second is for, I will take our company as an example. This is a company that has had a very large innovative footprint in diabetes and cardiovascular diseases for decades. These medications are now off patent. So the commercial incentive to drive them, quite frankly, is limited. It's not negligible, but it's limited. And we find it important to continue the life cycle management for these in a way that promotes global health. Let me give you an example. Metformin is first-level care for diabetes, and the efforts we've done to develop the pre-diabetes indication to work with WHO to recognize this as a disease and to prevent diabetes with very simple measures with a drug that's 50 years old is probably something that not many pharma companies would choose to do in a market that's 86% genericized. But it's about the patient. Finally, when you come to one of the most dire NCDs, which is oncology, and you've had the chance to see the care of oncology in even the major African cities, such as Nairobi or Accra or I'm not even talking about the field, where you have the Aga Khan Hospital in Nairobi with the ultimate care, as you have in Berlin Charité, and down the street you have Nairobi University, with one physician seeing 200 oncology patients a day. You embark on a long-term effort to build capacities to at least provide some hope in oncology for these patients, because what you see honestly is dire, and I'm humbled. It's a start. It's a slow start, and but it's a start. I will not claim major successes. These patients are in very, very dire need.
Thank you. Sandhya?
Thank you. Yeah, I'll respond to two questions. One is on the issue of allocation of resources. The example of polio was taken. I would just say that when an organization decides to allocate more on one versus the other, it's not that you think that's more important and the other issue is not important. I mean, the health space, as you all know, is many, many issues, and actually the canvas is very large, and every organization has to draw the boundary somewhere. For the Gates Foundation, the whole space of infectious diseases has been a very important area. In some part, not the only reason, because of the externalities involved and the implications of that, and that's been one of the issues for the large focus on polio. The other issue, the other question, on the accountability of the private sector. I would first say that much as, the whole issue of private sector accountability comes up often. It's not as if only the private sector has accountability challenges. The public sector also has accountability challenges. So it's in all spheres and spaces. And when I was talking about a transformative health system, when we look at the whole issue of provisioning and purchasing differently, the idea is to seek accountability, again, from both private and public through an architecture that is actually aimed at better accountability. That's one. And the other is, Adnan had at the beginning talked about community, and I didn't get into that actually, but community has a very, or patients have a very important role to play. The challenge is that the nature of health care and health services is such that there is an enormous amount of information asymmetry. And because of the challenges of not having the right information, it's difficult for patients or community members to actually hold anybody accountable. But with mechanisms in place, with greater awareness, information, and building the voice of those who currently don't have a voice, we may be able to move towards more accountable systems.
Thank you. Rüdiger?
Thank you. Alex, the colleague from Harvard, you asked about the financing, the top-down financing, the bottom-up financing, and if I understood your question correctly, you were asking about how equitable should health systems be. Now, we have a lot of evidence that systems that have actually distribution mechanisms where actually the young pay for the old, the healthy pay for the unhealthy, and the rich, the wealthy, pay for the poor. These are those systems that actually contribute to human capital and contribute to social and economic growth. So we have an incentive of creating systems that actually do exactly that. Now, we have a challenge here indeed, because we see that in many countries we don't have that. We have what we call in the health systems world, we call it cream skimming. That means that health insurances have an incentive of insuring the rich and the healthy and the young. And they don't cater about the others. And then you have systems, and that's very basically the public sector then, that caters for all the others. That is the old, the frail, and the poor. And that doesn't work. It will not work. If you create a system for the poor, it will be a poor system. Right? So we have an incentive in WHO, but also with our partners, to reverse the trend. Now, we set out this $3 billion goal in 5 years. That is, if we want to achieve the Sustainable Development Goals. And to respond to a couple of other questions on the private sector, we cannot do this, we cannot achieve this without the private sector. We're all convinced about that. Now the question is, how do we engage with the private sector? And Stefan, I think you've given a good example, how a company then actually takes responsibility in this. Now, the question for me is it enough? Or can we do it even better? And I would think that you could have an incentive, but also an interest to do a business which is credible, which is socially responsible, but which is also profitable for you. Because we have about 400 million people who currently don't have access to secure medicines. So you have a huge market, but you have challenges in accessing it. If we merge, if we actually get all the partners together, I'm sure that, Minister, I'm sure that the access can be improved.
Thank you. Honourable Minister, any reflections?
If we get all the partners together, you're sure, I'm sure, that access can be improved. And I was going to challenge Merck to begin to realign its business model and its philanthropic model and look at how access to medicines for oncology, that is unique, right, will come to the 200 or so people that you are talking about. Medicines for oncology cases are a bit expensive. And in Africa, I can't talk about 50% of people being able to procure access by these medications. But there's a company that is doing market shifting. Same medication, different price in Europe, different price in Africa. As much as about 50% down. That is an effort to try to put the medicine to the reach of poor people. We're talking about oncology specialists that are not adequate in Africa, including my country. Ghana, I forgot to mention, as part of our health system strengthening issues on HR, we have actually announced the free training for postgraduate education for medical officers. So you want to specialize in our college, you wouldn't pay any fees at all. Hitherto, it was a bit handsome, but now all medical students can go to the college to do specialization without paying anything at all. Again, a company like Merck, partners, can support to train, people outside even our country, with some scholarships and things like that, that can help increase the numbers. But then they sign some MOU to return when they finish their courses. Partnerships, you can support us to build partnerships. Right, I cited 2 examples. Assembling the team of oncologists, for example. Go sit in Accra, 15 days in a year, just 15 days. Try to see how you can support, clear the backlog of patients that need interventions. I believe these are things that can help. And they will go with knowledge and transfer to their colleagues back home to try to do what they can do here, even after they exit. So these are windows and opportunities that we can tack on. Alex, we're talking about misallocation of health resources. As if we have identified all our priorities and we have a pot of money, resources that we are distributing at one particular point. Unless, of course, we are talking about misuse, but I pick the word misallocation. It's difficult. Gavi funds will only go for immunization. They wouldn't talk about non-communicable diseases at any board meeting at Gavi. They are looking at how we can cover preventing diseases that cannot get to children. So will you call that misallocation? Based on your priority. So each organization has its own priority. Governments have their own disease burdens and they have their priorities. Global Fund will look at 3 big ones with support from Bill Gates Foundation. So globally, that type of question and this meaning becomes something that we can't easily comprehend. But I believe your allocation and getting optimal allocation will depend on what you have picked as your priorities and what pot of resources that you have. In country, when somebody asks me my priorities, I find it difficult to answer. Honestly. The broad thing that we are looking for now is universal health coverage. Mm-hmm. Where do I put little government budgetary resources to achieve that? Do I go 100% primary health care and neglect non-communicable diseases? Should I pick on neglected tropical diseases? Do I go supporting malaria vaccine development? So you see what it is. And therefore, you have to sit down and run models to try to see how best you can allocate bigger resources, no matter how big they can be, to see what optimal outcomes you can achieve. We're talking about SDGs. Even go three, several targets, I think 17 or so, for health. Which particular one becomes your priority? All of them. And therefore, when you're allocating resources, you need complex models to be able to reach optimal levels for all these little tiny priorities. But that's a difficult question, but it prompts us, those in office, to do allocation of these resources, to do the best that we can do for efficiency gains, as we can. We look forward to achieving SDG goals and ultimately the universal health coverage. Thank you.
Thank you very much. I think the discussion raised is critically important here. And I actually really emphasize the question that is being asked around resource allocation, because we don't have an ideal answer. The one thing that we often possibly can say is that the rational allocation of resources, completely based on evidence alone, may not exist. And so the pulls and pressures from many, many different spheres actually plays on that. I'm going to try and see if I can get one or two more questions in, because I think this is very helpful for our discussion. We started 5 minutes late, so I'm going to end exactly at 10:35. So a couple of quick questions. A lady right here in this row, and a gentleman right at the back. I can't actually even see him, but he's right at the back. Yes, sir. Hang on, let me ask quick questions, please. Yes, go ahead.
Hi, my name is Rosemary Morgan. I'm on faculty at the Johns Hopkins Moorburg School of Public Health. We know that more diverse leadership structures help for making effective and efficient policies. We also know about 75% of the health workforce is made up of women, but only 25% of those that lead within the health system are women. So what are you doing in your organizations to help encourage more women in leadership positions?
Excellent question. In fact, I was going to cancel the panel had Sandhya not appeared, because thanks to Sandhya, the panel was going on, because I don't get on panels unless there's both genders represented. Yes, sir, at the back. If you can quickly ask your question.
Michael Hyder, Global Healthcare Programs, Bayer AG. Question to the price of the medicine, which we all aim to reduce to the end patient. How are we going from a system side to address the challenge of increasing prices through fragmented registration systems, the request of 75% shelf life at destination in a country, the fragmented packaging in each country? It's all driving costs on top of what is happening. So sometimes we even see higher prices in Africa if the export price is the same than in Europe. Thank you.
So thank you very much. So we have two questions, one around diversity and one around pricing. I'm going to go this way. So Honorable Minister, if you can all maybe take just 2 minutes and add any other closing comment that you would like to add, so that I can wrap up once this round is done. So starting with you, sir.
Encouraging women. I think that is an agenda of almost all countries now. Try to get through women into health systems. Ghana, close about 80% of our nurses and midwives are women. It's a fact. We saw it as a women's profession, and not very male people were getting in there. It's only these days that young men have found interest in getting trained as nurses and midwives. Fortunately for us, it looks like even at the medical officer level, we are getting more women now than men. In all our teaching hospitals, the universities, virtually admission is taking close to about 54% female to males. So going forward, not with conscious government policy, but dynamics are making a shift for us. Pricing. Ghana was one of the countries that had high prices for medications. But I said earlier on, removal of VAT, we're talking about registrations, fragmented packaging, and all those things. These are marketing issues that can be dealt with or, approached by pharma companies. But we didn't talk about profit margins in that virgin area. But I believe that is one area we have to look at, not necessarily looking at how we can remove expenditures by conscious policy. That is going to be a bit tough. But I believe not too much profit, looking at how best you can support the globe achieve two big things, SDGs and universal health coverage. Pharmaceutical companies have a lot to give us. Thank you.
Thank you very much, sir. Rüdiger.
On the first question, on the gender, we have a new administration for the past year. Dr. Tedros has taken up his position as Director General just a year ago. The senior management is 56% women, and that means the Assistant Director Generals and the Deputy Director General make up 56% of women. The basic question, though, is not whether it's, the organization is led by a woman or a man. I think what we can see now is a different culture. We're engaging in a huge culture shift in the management of WHO. We try to listen more. We try to have meaningful technical discussions, understanding the different options that we've got, and taking concise decisions afterwards. And it is a pleasure to actually work in a much more balanced way. So it's not just women or men, it's just also how we do management. On the pricing, I'm so grateful for that question as well. And when I said that we need to engage more with each other and and really look also at the private sector to contribute to the 3 billion in the next 5 years, it comes with prerequisites. And that is the accountability, of course, the transparency as well. And that has a lot to do when I look at the pharmaceutical industry. I'm not looking at you, Merck, but I'm looking at the pharmaceutical industry as such, which in its pricing currently is extremely intransparent. So to open up markets, to open up the access, like you said, Minister Manu, actually comes with the requirement of also being much more transparent about the calculation of prices in the pharmaceutical industry, so for the medicaments. And it is, again, I think the industry needs to be profitable, but it needs to be realistic also. It needs to be reasonable. And I think that is what many, many people demand from the industry, that we actually are clear about what we are paying for. You want to know this in the services, but also in the products. So therefore, I'm grateful that we've engaged with quite a few member states on a pricing forum. So where we actually look at what sort of alternatives would we have in increasing transparency in the calculation and not having confidentiality agreements with countries not to talk about the prices that pharmaceutical industry takes, which actually creates even more intransparency.
Thank you. Thank you. Sandhya?
So on the diversity question, it's a great question. And in fact, what I would add is, to the statistics that you gave, not only are there a very, very large number of women at the lower levels of service provision, so many of them are ostensibly working on a volunteer basis, and it's not even formal employment. So it's a fairly problematic situation. The foundation, internally, within the foundation, we're very cognizant of it, and I think the balance is fairly okay. But that was not your question, and I think that's not the point. We are very focused on seeing how we can support the building of women leaders on global health. So we are very recently, in fact, we had a conversation foundation-wide on actually focusing on this area and promoting women leaders in global health. So it's something we're very cognizant of, and we're hoping to contribute to that. But more broadly, and just in terms of sort of closing, as you asked, Adnan, I would say that a couple of areas for all of us to focus on is, one, building institutions actually that can, or strengthening institutions that can support the journey of health system strengthening, and simultaneously human capacity. How can we support the strengthening and building of human capacity in this space? And your question would be part of that. Very often we see that political commitment and political will comes from the extent to which public at large is actually demanding something. And it's not entirely clear whether in a large number of countries actually public is demanding health and seeing health as an entitlement. In some countries, yes, and it's very much an electoral issue, but I think in a large number of countries, especially from the parts of the world that I come from, it is not. So a very big challenge for all of us is how do we make health a political issue, an electoral issue, so that political leaders remain committed to prioritizing this.
Great point. Thank you. Stephen.
Diversity. 2 levels, the internal level, the external level. Let's take a snapshot of the people that are relevant for today's presentation. The CEO of Pharma at Merck is female. The head of the Global Institute, Merck Global Institute of Health is female. The head of corporate affairs is female. In my area, drug safety, we have 80% women, 60% transfer into the leadership of that area. Now, as a disclaimer, we do believe in the professional future and the potential of men at Merck. Right? We value diversity. So we are making progress. If we take the external look, we support programs such as Healthy Women, Healthy Economies, which in our business, in our external business, looks foundationally at how developing economies do. If you provide basic health care for women in those countries, and research shows that the more healthy lives you produce, in particular in the childbearing age of women, the more prosperous typically economies are. So there's a broader corporate look at this, which perhaps is more important than the internal piece. But I think that's making progress as well.
Thank you very much to my panelists here for responding to those questions, and also for being willing to come here and participate in this dialogue. Before I summarize, one housekeeping announcement. Tonight there's a joint Grand Challenge and World Health Summit dinner for which you will need to get on buses at 5 p.m. In order to get on that bus, you need a wristband. That wristband is available at registration desk. If you don't have a wristband, you can't get on the bus and you won't be able to get entry into that. So I was reminded to make sure that announcement is done. But just to summarize, this is an incredibly powerful panel. I think we've been frank in our discussion. We've raised the issue of how different sectors can work together with health system strengthening, how on-the-ground analysis is really needed, both in terms of successes, but also the challenges for achieving SDGs and universal health coverage. But maybe I can leave you with a thought that has been plaguing me as well, which is that we have these discussions and we have nice agreements and policies, and yet the real action on the ground lags behind. And so in some ways, what I am now increasingly talking about in my own work in global health is no more words. We want action, we want implementation, we want less policies, agreements, and beautiful signing ceremonies. We want real implementation of solid interventions that enhance health system strengthening. So think about that. Engage in health system strengthening around the world. Thank you very much to all the panelists and to all of you for participating today. Thank you.